This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
Pills alone do not build skills. So we need more than the medication, and the skills are just so important.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm continuing my conversation on ADHD diagnosis and management with Dr. Aoife O'Sullivan and Dr. Brian Osborne, based on Aoife's distance learning article published in the March 2025 edition of Forum magazine. This is part 2, so if you haven't yet listened to part 1 yet, please take a look in the show feed where you'll find part 1. Have a listen there before coming back to this episode. In today's conversation, we'll discuss setting up dedicated clinics in primary care to manage ADHD, provide an overview of management options, including psychosocial interventions and medication options, and provide a review of resources currently being developed by both the Irish College of GPs and the HSE to support GPs in this area. As usual, you'll find links to all resources mentioned in today's episode in the show notes. Aoife opened today's episode by discussing the practical aspects of diagnosing and managing ADHD in the primary care setting.
I do work with ADHD patients as a GP, and I absolutely can see that the time taken to do an assessment just doesn't really fit with a typical 10 to 15 minute GP consultation time, that the time just is much longer. And that's the right thing. It needs to be longer, and I would see nothing wrong with that, but it doesn't fit with the GP model currently. So there are some GP practices around Ireland that privately have already set up ADHD clinics where they would have a system where GPs have the time to spend. The fact that the patients do need a mental health examination is to fulfill criteria E, that the symptoms are not better explained by another condition. But the reality is the majority of patients, now not all, some are very complex, but a lot of patients that the mental health conditions they may have will be around anxiety and depression. Sometimes maybe borderline personality disorder or OCD symptoms. And a lot of the time, these are mental health symptoms that GPs manage all the time. We actually don't refer all of our patients with their anxiety or depression to secondary care. So in some ways, GPs are more used to managing people with lower levels of anxiety and depression than psychiatry are. So I think it's very manageable as a GP to learn about ADHD, to do the extra training and to help manage these patients and prescribe for them. But it's not doable in the current setup that we have for GP practices where you have 10 to 15 minute consultations. It's just not possible. So perhaps as time goes on in the future, that model might become one that is, attractive to GPs and patients to have this, to have ADHD diagnosis brought into the community. In fact, we're doing some research in UCC, which is starting in January, with Professor Emma Wallace, who's the Professor of General Practice in UCC, around this very area of GP training and managing ADHD in primary care. But this research is just really, it hasn't even kicked off yet. It's the future is bright.
And just to clarify, and I suppose it is worth emphasising the point, Aoife, I would have thought, originally that I needed a consultant colleague in psychiatry to make the diagnosis. But that's not the case. If you have the appropriate training as a GP, you can both diagnose and manage.
Absolutely. And if you look at the NICE guidelines and the Irish National Clinical Programme Model of Care guidelines, they specify ADHD specialist. And I think my assumption was that meant automatically a psychiatrist. In fact, when I was reading the documents, my mind even sort of substituted the word. And I had to look back afterwards and realize, no, it says ADHD specialist. It doesn't say psychiatrist. Now, for somebody with very complex problems, particularly if there's any comorbid, perhaps, bipolar affective disorder or more complicated conditions, it would be important to have psychiatry involvement. But with what sometimes is called ADHD simplex. We can manage as GPs with supervision and working with colleagues. I think that is very important as well, though, that we would have a network around us that we can speak to discuss cases. I think it would be very difficult to do this completely on your own.
Thanks for that, Aoife. And Brian, we're going to move on now to management. And going back to the start of this conversation, you mentioned your own journey in ADHD management. You specified that once a diagnosis is made, people can be offered psychosocial interventions plus or minus medication, which I guess immediately gets me away from the concept that ADHD equals stimulant medication.
Yeah, absolutely, John. I think when we talk about psychosocial modifications, like lots of patients may have done a lot of this work themselves already, but if they haven't, it's good to signpost them to what they can do. So, for example, patients find it difficult to get out of bed in the morning. They'll turn off one alarm. They might have set 3 alarms in 3 different parts of the room to help them get out of bed. When they're trying to arrive to appointments, you frequently see it when patients are coming for assessment. They actually arrive an hour early because they know they're going to be late if they don't deliberately arrive early. So it's quite useful to talk these issues through with patients. We also see environmental modifications, sometimes be it students in classrooms or in exams in particular. They might need quiet rooms, they might need quiet spaces. Sometimes they'll use headphones for to muffle noise. They'll sit away from windows so they won't be distracted. So there's lots of these things that people can use. And actually, movement breaks are another thing that, especially for the younger teenagers and any age teenagers, sometimes they just feel this need to move and not be seated, not be in the classroom. And that can be, there's accommodations that take place both in workplaces and in schools around these type of issues. So they're the environmental modifications that can happen. There's also ADHD Ireland, which is a really good organisation for patients to look into, and they run a course called UMAP. It's understanding and managing ADHD in adult patients, and it provides it's done through the ADHD Ireland and the UCD School of Psychology, and it combines that kind of psychoeducation piece with what's called an ACT, or acceptance and compassion therapy, and they just basically teach people about how the neurodivergent brains work, and it really helps people to understand what they're going through. The National Clinical Programme for ADHD, for adult ADHD, also developed an app with ADHD Ireland, and there's an ADHD adult app available as well, which again is another good resource.
Thanks a million for that, Brian. And you mentioned a number of resources and the app, and I'll include all of those as links in the show notes so listeners can dive a little bit deeper as they please. Aoife, for those patients, and we've made the diagnosis, we've gone through the psychosocial adaptations that can be made, as Brian has outlined. Let's move on to medications now. Could you give me an overview of the options and what to look out for, please?
Absolutely. Just one thing on the ADHD Ireland and the UMAP is that you don't actually need a diagnosis to do the UMAP program. That can be done by anybody who identifies as having ADHD. So patients don't have to wait for what could be, a long waiting list to get a diagnosis. However, to get medication, yes, you do need to have a diagnosis. And the medication would be prescribed, certainly initiated and titrated by an ADHD specialist, whether that's a GP with extra training or a psychiatrist. So the main medications used in Ireland would be methylphenidate and lisdexamfetamine, both of which are stimulants. So methylphenidate has lots of different names. You'll hear about Ritalin or Ritalin long-acting, which, Ritalin immediate release and Ritalin long-acting. There's Concerta, which again is long-acting. There is Equisim and Medicanet, again, both long-acting forms of methylphenidate. And lisdexamfetamine is known in Ireland as Tyvence, again, a long-acting version of an amphetamine. There are several others that are available, but they're off license, such as guanfacine and bupropion. So they're the main ones you'll come across. They are licensed in children from age 6 and up. and absolutely considered to be safe in adults as well, as long as there aren't any cardiac risk factors, and that has to be screened for as part of the assessment. So if it's safe to go ahead and try a stimulant, they would be initiated at a lower dose by an ADHD specialist. And as Brian mentioned earlier, we do like to use the long-acting forms rather than the short-acting forms of these medications because they are safer and they genuinely work better. Once the medications are started, it is important that I suppose even before they're started, that the patient would have a blood pressure and a heart rate check, as well as cardiac auscultation and a weight check. The weight check is because the medications can interfere with the patient's appetite, and particularly in younger people or teenagers who are growing, that is very significant, perhaps less so in adults. So they would have their blood pressure check, they would start their medication, and as with most medications, we'd start usually on a lower dose. And that medication would be slowly titrated at intervals with their ADHD specialist, with blood pressure and heart rate checks and weight checks being done at regular intervals until they're at a dose where they feel that they aren't getting side effects and also that the benefits are coming through. I think for me, when I'm prescribing, I think managing patients' expectations is extremely important. That patients can sometimes have an exaggerated idea of how the medication will work. They'll be the best person at studying in the world ever. It doesn't work like that. It takes a little bit longer. While the medications do work very well, they work for 60 to 80% of people, which is very high in mental health. They do take a little longer to work, and they're considered to be working if symptoms reduce by 50%. We'd be pretty happy with that. So it can be managing expectations. It's important to monitor blood pressure and heart rate particularly, and to titrate, in a cautious way. Once somebody is on a medication, whether it be Concerta, Equisim, Tyvence, that they are happy with and that the dose that they are happy with, we can then continue the medication, and they would get a blood pressure check, heart rate check, and weight check every 6 months. Now, this is in adults, so it, maybe a little less onerous. For prescribing, these are controlled medications. So in Ireland, so you need to warn the patient that it's important that they fill their prescription within 14 days and that they can only get 1 month of the prescription at a time. So that obviously makes it a little bit more complicated. We can, in essence, give a 3-month prescription, however, by using this idea of installments. For example, I could do a prescription for 90 tablets of Concerta to be dispensed in 30-day installments. So the pharmacist can, in this way, dispense essentially 3 months of Concerta by doing 90 tablets, please dispense in 30-day installments. So it is a little bit of a workaround those limitations on the prescriptions, but still the filling within 14 days and having to get the prescriptions on the correct days is still more difficult than your typical prescription. So it can cause some stress or frustration for patients. And we do, unfortunately, sometimes have shortfalls in pharmacies where the medication isn't always available, which can cause a lot of trouble. So they're not straightforward prescriptions. And again, I suppose like everything, if you're getting used to prescribing, you do become more familiar with them. We would also warn people when they're starting, like with any medication, to be careful about the time of day that they would take the medications, usually in the mornings, to avoid alcohol if at all possible, to reduce caffeine because, stimulants like caffeine can increase your heart rate. Warn about effects on maybe appetite, particularly in people who are still growing, but at any stage. And funnily enough, vitamin C interferes with the absorption. So I tell people not to have vitamin C at the same time as taking the medication. So the medication, however, for many people, not for everybody, but for most people is really helpful. It makes a huge difference to symptoms once you're on the right dose of the right medication. We do also have one other one called atomoxetine or Strattera. That's a non-stimulant medication. It is easier to prescribe because it's not a controlled medication, so you can give a normal 6-month prescription. However, the response rate is a little lower. It's probably about 50% response rate. So the response rate wouldn't be quite as good as with the stimulants. and it does take longer to kick in. So you have to be a little more patient with it, allowing about 6 weeks for it to kick in. So they would be the main medications on the market in Ireland, though you may see other medications being prescribed in other parts of the world.
Okay, so many thanks for that, Aoife. And I guess getting back to the landscape in 2025, many of these diagnoses continue to be made in psychiatry. And as we all know, as working GPs, oftentimes a moment comes where psychiatry will write to us and ask us to take over prescribing duties for a patient that has been diagnosed with ADHD under their care, to take over prescribing and to take over the cardiovascular monitoring, etc., that goes with that. Brian, that can be a bit of a knotty issue. Is that something that you could address?
Yeah, that's a difficult area, John. I think many GPs, like many psychiatrists, or most GPs and most psychiatrists, do not have training in the management of ADHD. And so for psychiatry to ask GPs to do work that is not resourced, that they haven't received training or education in, for me, is inappropriate. Now there are some GPs who have trained in ADHD, and it's within their scope of practice. And if they feel comfortable doing that, then that's something that they can go ahead and do. But in the main, for work that isn't resourced and no training has been applied to it, and also at the college AGM in 2024, a motion was passed unanimously that the college will work to protect GPs from unresourced work. So it's not something that the college would be proposing.
Understood. On the other side of that coin, Brian, college is working to help GPs to develop their own skill sets to be able to manage some of these patients in a more comprehensive manner.
Yeah, so at one of the Wednesday webinar series in October 2023, GPs were asked in a poll which mental health topics they would like further education in, and ADHD education topped that poll. And I think that reflects the number of inquiries that we're all seeing as GPs every week, really. So on foot of that, Aoife and I and the education team within the college proposed an online on-demand training in ADHD for GPs. And this was approved by the College Education Committee in 2024, and it's in the process of being developed. But in parallel with that, we are also engaged with the National Clinical Programme for ADHD. So a model of care was launched, I think it was in 2020, 2021, around then. But it's out of date, and it's out of date because of the huge increase in demand, and they are unable to provide care for all the referrals that they're receiving. So we're engaged in a program where potentially GPs would be trained, interested GPs obviously, and they can have different levels of training: level 1, level 2, and level 3. Similar to the methadone treatment program that is there right now, and it's in development. It's not signed off yet, but it's something that might provide a solution to the ever increasing demand for patients who want to be assessed for ADHD.
And indeed, that ever increasing demand is something that Aoife signposted in her forum article around the experience in the NHS and how there's a risk of overwhelming the service, such as the level of demand in the UK services. So that's the ICGP, that's the college work that's underway, Brian, in terms of assisting GPs to develop their own educational skill set around managing ADHD. And Aoife, there are some developments underway at HSE level 2.
Absolutely. This is also a very topical consideration in the HSE as well. They do recognise that their services are not meeting demand, and steps are being put forward to try and increase what the HSE can offer. So in CAMS, we have a new national clinical lead for CAMS ADHD, who is just in post since 2024, Dr. Aisling Mulligan, and she is in the process of developing a new model of care for those under 18 presenting with ADHD symptoms. And part of this model of care now. It's only been drawn up. It's in, it's absolutely a bit away from being published right now, but it would look at increasing the numbers of people, for example, who can diagnose ADHD. So maybe pediatric neurodevelopmental teams might be able to be involved, and perhaps ADHD specialists, maybe advanced nurse practitioners. So to try and increase the number of people who can diagnose ADHD safely, and then acknowledging that while psychiatrists need to prescribe the medication, for example, that psychologists can actually do the diagnosing. So hopefully when all of this comes together, which is perhaps a few months off yet, it will allow for more people to diagnose ADHD, which should help relieve some of the bottleneck that we're experiencing. Because in the HSE waiting lists, a lot of those waiting lists in CAMS can consist of children with ADHD who are sitting waiting. And because those ADHD assessments are quite time consuming, it really does add to the overall CAMS waiting list, which we all know is an ongoing issue. In adult ADHD, I think, as Brian said, the acknowledgement is there that the model of care that was published in 2021 was really out of date almost as soon as it was published, due to the massive increased demand for ADHD assessments. And again, with the adults, looking at, can GPs get involved, again, psychology, to again try and address that bottleneck for getting ADHD assessments. I do think it's important, though, not to over-focus on the diagnosis, because that's what everyone tends to do, and to recognise that there is a significant amount of work beyond the diagnosis. I think all of us tend to focus perhaps a little bit on just getting this diagnosis, but there isn't a magic wand that comes with getting the diagnosis. The whole process of the psychosocial education, doing the maybe acceptance and compassion therapy, and then the whole initiation, titration and maintenance of medication is quite the workload in itself. So not to get too focused on the bottleneck of diagnosis, and realize that there's a fair pathway after that as well. But certainly, I think almost everybody between HSE, ICGP, and in Ireland and internationally recognises that we do need to increase the capacity for ADHD diagnosis.
Thanks, Aoife. And one of the many, many takeaways that I have from today's conversation is that UMAP 6-week workshop. And as you clarified for me, you don't need a diagnosis to participate in that. And I certainly will be signposting some of my patients who are sitting on waiting lists or trying to save for a private assessment, that they can get going with some psychosocial options straight away, which is really great for my own practice. So thanks for that as well, Aoife. Brian, do you have any take-home messages that you'd like to share with listeners?
I think the take-home message, John, would be to just remember that ADHD is real, even though there's a lot of social media stuff on it, which is not particularly helpful, but it is real, and patients can be very distressed when they have it. So just, I suppose, like we encourage for all patients to be kind and be compassionate to those patients when they do present with their symptoms. And just to get back to Aoife's point there, a diagnosis is not the be all and end all. It's really it's the skills and pills, because sometimes people focus on a diagnosis and I'm going to get this medication that's going to make me into Einstein, but that's not the reality. It's about hard work of the psychological stuff, the environmental stuff, and sometimes medications can be appropriate and can be very helpful, and it will help you to reach your potential. But it's not going to get you 6 H1s in the Leaving Cert, which I think some people think it will.
Okay, thanks for that, Brian. That's very helpful. Aoife, I really enjoyed that article. So congratulations again, the forum article from March 2025. And I'm going to include a link in the show notes. If you'd like to add anything on your side, I'll leave you with the final word.
Thank you. I think, the phrase I like to use there is, pills alone do not build skills. So we need more than the medication, and the skills are just so important. Though I think for some people, it does help to have the diagnosis, because then they can concentrate on the developing those psychosocial skills. And I would just echo what Brian said, that ADHD is real. It is very much part of the spectrum of living, that neurodiversity is a spectrum that sometimes you will have maybe times when it isn't bothering you so much in your life, it will fluctuate. And there are other times when ADHD symptoms can be incapacitating. So times around transition, maybe going into secondary school, into third level, leaving cert year, sometimes people go into postgraduate where there's less structure. And then times around, big life events like the perinatal period or even the perimenopausal period. These are all times when ADHD symptoms that maybe otherwise you're managing quite well can become more debilitating and can cause a lot more stress. So there are times in your life when these symptoms that can fluctuate become more apparent, and it's not that somebody's making it up. And the symptoms just have become more difficult to manage at certain times, and to be very open to patients when they notice these things. So I think that is just a really important one, and that sometimes medication might be needed, and then maybe other times they're managing well with the skills they've built up through UMAP, through maybe some occupational therapy or ADHD coaching, and maybe the medication isn't in the front and middle. So pills don't build skills, but pills at the same time, those medications are very effective medications, and we do see people do really, really well on them.
Many thanks again to Dr. Aoife O'Sullivan and Dr. Brian Osborne for speaking to me today. And don't forget to check the show notes for chapter markers and links to resources mentioned in today's show. If you have any comments or feedback on today's episode, or indeed suggestions for future episodes, please let us know. You can contact us at podcast@icgp.ie. And that's it for today's episode. Many thanks again for listening, and until next time, take care.